So, afternoon everyone. Welcome to this Healthy Hearts Yorkshire and Humber HSN diabetes education session, where we're going to be discussing the role of SGLT2 inhibitors in managing CVD risk in type 2 diabetes. And actually, we're going to be talking about those with established CVD in relation to this as well. I'm Pete Waddingham. I'm a programme manager here at the Yorkshire and Humber HSN, and I'm delighted to say that we've got some great speakers lined up to take you through some of the work that we've been planning for Healthy Hearts for a while now. Actually, we got into this piece of work before COVID, actually, or we were just in the planning stages. And I was reflecting before I came on today. With Healthy Hearts, we wanted to do a very distinct piece of work with diabetes. We know diabetes covers lots of areas, but we felt that the introduction of SGLT2 inhibitors, which Wakas and Rani and Hannah are going to talk to you about today, was a good place to put some focus where we could potentially do something at scale. So that doesn't mean that we're not acutely aware of all the great work that's happening across diabetes care, but for the purposes of this project, it's very much focused on this piece of work. So the speakers today, sorry, just someone's come on the line if you wouldn't mind muting yourself. Dr. Wakas here, West Yorkshire Health and Care Partnership Diabetes Clinical Lead. And he's going to be taking you through some of the work and some of the context and background to this project. Hannah Bieber, consultant pharmacist for diabetes at NHS Leeds CCG and embedded in the Leeds GP Federation. And Hannah was brilliant in horizon scanning some of the new changes to the NICE diabetes guidance, which she's going to talk to you about in a minute. And Dr. Rani Khatib, a consultant pharmacist in cardiology and cardiovascular research at Leeds, as well as lots of other really useful hats, clinical champion for PCSK9s and lipid management with NHS England, and also on the European Society of Cardiology. So those are the speakers today. Just a couple of learning objectives. What we'd like to do today, we obviously want to brief you on the work of the West Yorkshire and Harrogate Healthy Hearts Diabetes Treatment Guidance, give you a bit of a flavour of the newly revised NICE guidance, because that has only happened sort of last couple of months really. So Hannah's just going to touch on that briefly. Rani will be giving you an overview of managing cardiorenal metabolic comorbidities, so how we're starting to try and wrap all of this up when patients have these kind of multimorbidities. And then finally, I'm just going to touch on very briefly some of the resources that we've got for PCNs to help them with some of this work. And I'll probably kick myself if I don't give you a little flavour of some of the wider Healthy Hearts work. We're planning to save lots of time for Q&As because we wanted this to be a little bit more interactive. Sorry, if you could just pop yourself on mute if you're not talking. We'll see how that goes. Obviously, I don't want to put people on the spot if they don't want to ask questions, and we might just get the panel to have a bit of a discussion. So without further ado, I'll hand over to Dr. Wakas to hear.
Thank you very much, Pete, and welcome to everyone. Pete, can we go on the next slide? That would be brilliant. And I think first and foremost, I think it just highlights, like Pete alluded to, in terms of what our main goals and objectives are when we set out. I wanted to highlight before we look at the context and where then I'll just briefly, outline where we've come to, what our journey looks like, and what we've created and what we wish to achieve with this. One of the things I just wanted to highlight was that one of the main purposes of the Healthy Hearts project, and it's important to remember the sort of main strand or thread that we breathe as a wider sort of Healthy Hearts family and amongst all of us as colleagues, is that the main focus was just when it all started several years ago with Yusuf and the team, was around improving cardiovascular disease or cardiovascular outcomes for our patients across West Yorkshire. And it was really just focused on risk factor management. So if we look at it, phase 1, which started a few years ago in Bradford and then spread across West Yorkshire. Now other areas are taking up, Humber, Coast and Vale, down south, Greater Manchester. They're all little pockets that are emulating the fantastic work under the Healthy Hearts project that everyone's been contributing to, was focused around blood pressure management. It then evolved to phase 2, where the focus was, predominantly around two fourfolds, I'm going to say, around lipid management in general, in terms of increasing uptake of statins, optimization of lipids. And secondly, there was also a sort of subthread of that focusing on familial hypercholesterolemia. That's where, I'm very fortunate when we've entered the 3rd phase and the focus has shifted to diabetes, that we have got a wonderful team in the speakers today as well that have sort of helped us move forward with this. So first and foremost, before we even jump into this, what this is not is a diabetes management guide. So I just wanted to lay that out there. We're not trying to replicate, duplicate, create some guidance. However, what we want to do is within the diabetes cohorts or patients or populations that we have, we are really focusing on those that are at the in a pyramid, at the top of that pyramid, those patients that have the highest risk of cardiovascular disease. So they've either already had an acute event, MI, stroke, heart attack, heart failure, or they've got multiple risk factors. And that's the main purpose of this piece of work. And here, as you can see on the screen, it just outlines really the vigorous and robust work that Pete alluded to. We started just at the start of the pandemic, which has taken us almost 18 months actually what we wanted to achieve. And we also wanted it to be really simple, really simple. That's what Healthy Hearts has always been about. Very practical, very pragmatic, some lateral thinking on it, underpinned by searches, education, and that's at the hub of and at the nub of what we wanted to do with this. As you can see here, we've had multiple wider clinical as well as commissioning stakeholder engagement events. It's then been through multiple committees, locally for us to agree, wider clinical groups to agree, commissioning colleagues to agree on it, and then the area prescribing committees. And then in and amongst all that, we've also, like Pete mentioned, is we've welcomed a nice guidance. That's really welcome news, since 2015, and I know Hannah will be touching on that. But again, we've just done slight tweaks align our guidance to that, so it is futuristic, as well as very focused for our main mission, which is around reducing cardiovascular disease within West Yorkshire, but with a diabetes add-on. So at the moment, it's been through area prescribing committee in February 2022, and it's just waiting to again be presented at the West Yorkshire Joint Committee in June. But otherwise, it's all done and dusted, and well done to the team for getting us there. And this is thankfully Pete's just put us some context in terms of, right, okay, what does the work involve? And I really like to know where we are. So what's our starting position of this? And this is just a mere reflection. And we have to remember is obviously we're coming out of COVID. There's a backlog. We're trying to reset and restart services. And this data is just trying to highlight in terms of, I look at it in terms of work to do or opportunities for us to improve care. And this just highlights some of that data. So the numbers at the bottom, which is the West Yorkshire total, as you can see from left to right, it looks at, number of people, for instance, where the HbA1c is not less than 75. So this is not to say that this is a number who have it less than that. This is to say that we've almost got about 20,000 patients who have an HbA1c above 75 millimoles per mole. And a lot of this data, I appreciate between January 21 and December 21, but even the latest data set, it's not massively different from that. So, some of it we could argue is COVID related, but actually, if we look at pre-COVID years, you're probably looking at not similar numbers there as well. And then you've got, HbA1c is above sort of 10%, we've got 10,000 patients. So we just wanted to highlight and wanted to show in terms of, there is a big gap in terms of the brilliant work that we're all doing and where we want to go, but also in terms of an unmet need. So we need to focus on these high-risk patients, whether that's just purely looking in terms of HbA1c or glycemia, blood pressure targets, the middle comes their statins. And for me, one of the things that really highlighted is the second column from the right, which is the combined prevention, not on statins group. As you can see there are still almost, just above 30,000 patients who usually we would commence them on a statin because of their high CVD risk. Either they've already had an event and not on it, as you can see by that number, 4,000 plus patients, or those patients who have got CV risk factors, Q risk above 10%. So we know by even current guidance, we should be encouraging them on the statins. And there might be underpinning reasons, not tolerate, compliance issues, X, Y, Z. But it just highlights that there is a significant proportion of work to do. And that's despite us having a brilliant workforce and a brilliant program underpinning this. And the last column there just highlights in terms of purely from a diabetes point of view, and that's extrapolated from the National Diabetes Audit in terms of all three treatment targets. So the treatment targets that we discuss in this column are different. So it's around optimizing HbA1c to less than 58, cholesterol less than 5, blood pressure less than 140 or 80. And again, this just highlights, to put numbers in perspective, that particularly will be looking at the number of people we have living with type 2 diabetes across West Yorkshire, which is just over about 150,000. So that's across all of our places or CCGs at present. And you've got a sizable chunk, more than half of those patients who unfortunately at present are not meeting that target. So the hope is by doing all of this work, optimizing blood pressure, optimizing lipids, some improvement around glycemia, and obviously with novel therapies that we can enhance and increase their cardiovascular protection. Next, please. Thanks. Okay, so this is just on a one-page. You're not going to be able to see on the screen. We're going to break this down, but this is as a one-stop guideline. So we're just going to break this down into a few pieces. So as you can see on the left-hand side of the screen there, it was the guidance as this. It just highlights the guidance there. The bottom we've got in terms of what therapies we want. As you can see, there's only 2 SGLT2 inhibitors. We want it really simple. Some supporting clinical information. So it's really easy to figure out when perhaps I want to start a patient, but also we want to make it safe for us as patients who perhaps are prescribing SGLT2 inhibitors. So just some clinical caveats and some important things to recognize in terms of when perhaps not to start it. So this is that enhanced guideline. So this is just around in terms of, as you can see, the first one is really, really crucial. So like we said, this is not to treat everyone with type 2 diabetes. We're not trying to replicate our guidelines. The focusing within people who have diabetes or living with type 2 diabetes, we're focusing on that top tip of the pyramid, which is the highest of the highest cardiovascular disease cohort. And as you can see, we're not trying to medicate everyone. The first line is really, really crucial for me. 2 main elements whenever we're reviewing any patient and with diabetes is we're still focusing, the first and foremost is around lifestyle advice, smoking, weight loss, exercise, moving more. Absolutely, we're all up for it and we're all behind that, and that's reflected in this guideline as well. And the second thing I think is really crucial for us as a health system, and that is where we really know that we need to increase and enhance both the offers of structured education or education packages or self-management programs for our patients with type 2 diabetes, but also the way we deliver that. So one of the key things we wanted to embed in our, if we look at it, ways of working nowadays was actually how can we increase lifestyle advice and lifestyle referrals, whether that's for weight management services, but at the same time offer a mode of structured education. Once we've done the basis of that consultation, let's have a look, what do we need to do with that patient in front of us? And we've split it slightly different, and I know Hannah will through the NICE type 2 diabetes guidance. We try to break it down what's important for our nursing, pharmacists, allied healthcare professional team, and also as GPs as well. In terms of the left, got is for newly diagnosed patients with type 2 diabetes who are low risk. That's what that group tells us. So these are treatment naive. They've got a Q risk less than 10%. They've got no CVD, no renal disease. So this group, in my head, always like we were graduating it. This is like the green group. So these are the new patients where they are low risk, and the advice in keeping with most, if not all, international guidelines as well, is we're just starting them on and optimizing that. We then move to, if we call it, the amber or amber red groups in the middle, and this is the bulk of the work which we believe our guideline and pathways would influence. And this is where we've either got newly diagnosed patients with type 2 diabetes, but they are different in this group. Why and how? That's because they are at high risk of cardiovascular disease. How do we know that? And there are a few searches that underpin that. They either have established cardiovascular, so heart attack, strokes, established renal disease, heart failure, or they've got a Q risk above 10%. And in this group, the first line of medication therapy is, as across all guidelines, is metformin. And the important thing to remember here is that once we've optimized metformin, we are actually trying to, in a way, rule out and eradicate clinical inertia. So as you can see here, box it says we're then wanting to add in an SGLT2 inhibitor. So a few things here: metformin, optimize straight away, and then we're jumping in with therapies to enhance cardiovascular protection. But also, in a way, we mustn't forget is that these are still glucose lowering drugs. So it's multifactorial benefits that we want to add for that patient at that time. And the other key thing to remember, as it's highlighted here, is we are adding in the SGLT inhibitor irrespective of the HbA1c. So that's probably a new change for us across diabetes care delivery as clinicians, is that we've always historically worked upon an HbA1c, a very glucocentric approach, where the higher the HbA1c, or if there is a deterioration in the glycemia, we'll jump to the next therapy and the next therapy, so forth. But here it's a very U-shaped turn on it, where actually what we're trying to do is identify someone's cardiovascular risk and then enhance the treatments based on that risk, irrespective of an HbA1c. Another concept, which I know Hannah will absolutely cover again, is once you've optimized the metformin, it's a change in our thinking here, particularly around diabetes, is we're adding in an SGLT2 inhibitor in a sequential manner. So what we're not doing is the historic way of, let's call it diabetes management, where we've done lifestyle and everything. We've started them on metformin, optimized everything, or waited 3-6 months, done some changes with metformin, waited another 3 or 6 months, and when things deteriorate, that's when we perhaps would have added an SGLT2 inhibitor. In the new world of thinking, we've given them 2 prescriptions. We've explained metformin, the patient's up titrated, and then at the end of month 1, for instance, they've started the SGLT2 inhibitor. And the idea would be that by month 3 or 4, that's when you bring them in for a review, in the hope that actually we've added additional cardiovascular protection, improved the glycemia, improved other parameters. You do the checks, and brilliant. You're also saving multiple appointments in the way, but more importantly for that patient is improving intensive early management for that patient in front of us. And then the third group towards the right here, you'll have is in those patients who don't fit into these boxes. So it's really easy for a new patient where you start with ABC approach, but actually what about all of those patients who perhaps are on dual or triple therapies? How do we align them with this cardiovascular thread and protection? And that's where the third group is very useful. So this is in patients who already have type 2 diabetes. They're already on oral therapy, but as you can see, we've got different HbA1c ranges. So the idea of this group is to actually pick up patients who are already suboptimal, where perhaps you would have done a medication change anyway, but then we're assisting that medication change. So here, the idea around it is let's start them on an SGLT2 inhibitor. And already in this group, they're suboptimal as well as at high risk of cardiovascular. So there's a dual sort of function or a dual benefit there as well. Next, please, Pete. Thank you, Pete. So as we all know, you probably would have had messaging either through clinicians like all of us, where we've either done talks, webinars, pharmacy reps who have probably visited you. There are lots of different SGLT2 inhibitors, and what makes it difficult is that they all have lots of different licenses, lots of different EGFR thresholds, lots of different SMPCs. Next, please. Or on the other one. There, thank you. And here we're just focusing on, after lots of clinical debate, lots of data crunching, we settled on 2 drugs which we believe at this point in time would have the most clinical licenses, as well as for what we wanted to do, which was focus around type 2 diabetes and CVD. So our first choice, as per the guideline, is empagliflozin, and we've got a second choice around empagliflozin, and particularly for those patients with CKD, where it license at the moment. And again, really simplistic messaging, 10 milligrams once daily. It says how to titrate up. And again, when we were talking earlier on about CVD risk stratification, what do we mean? You've got historic terms, primary, secondary. You've got the newer terms, which is basically CVD as a continuum. So look at it like a spectrum. That's where you've got those sorts of different risk factors in terms of Q risk, diabetes duration, multiple cardiovascular risk factors, and how we sort of delineate or muddy the waters a bit around that as well. And the middle group there, which is around supporting clinical information, that's really crucial for us, because as we all know is that, even after the pandemic, there was a lot of focus on weight loss, weight management, lifestyle support. So there are a lot of patients who perhaps are, trialing lots of different diets, whether it's a low carb diet, low calorie diet, multiple different diets. We really wanted this to be safe and effective and efficient, both for us in primary care as clinicians, but also for our patients. So that's where we've got some useful tips around when perhaps to either question the patient or perhaps not to consider an SGLT2 inhibitor. And a lot of these searches and a lot of these sort of queries we've actually taken out in searches. So one thing that makes the Healthy Heart program really good is where we've tested and trialed is that, and that people will take us through this at some point, is we've got System 1 searches that are embedded into System 1 for the Healthy Hearts program that actually does all this work for you. So it'll actually outline the HbA1c brackets, it'll exclude patients So in a way, it cleanses your list by narrow down the numbers, so you could actually just safely and confidently commence these therapies based on that guideline. I think that's
lovely. It is. Thanks for that, Wakas. And I don't know if there was a problem with my slides, and I was splitting around a little bit. I was getting a message that someone had taken control. I don't know if everyone could see them slides okay. Just bear with me a second, because Rani has just texted me. I don't know if he's having problems at the moment. Let me just double check. But Hannah, I was going to hand over to you anyway, so I think you do want to share your screen. So I will stop presenting now, and then you can take people through your section, please, Hannah.
Thanks, Pete. Do I have to press take control, Pete, to be able to do that, or not?
Not now. You just need to click share your screen. So
that's fine. Thanks. I'm not very tech savvy. Thank you very much. So thank you very much, Wakas. That was a great introduction to the guidance, wasn't it? So what I really want to do today is also go over a brief overview of the newly revised NICE guidance for type 2 diabetes in adults. I'm not going to go over every element of that, because obviously this session's really about the SGLT2 inhibitors, and some of it will be repeat of what Wakas has said with maybe a bit more detail put in there. So my name's Hannah Bieber. I'm in a RPS approved consultant pharmacist post at Leeds CCG. Something that I've been in for about the last 8 months, and I'm pending my own credentialing. So what does NICE say? So really out the door with the NICE guidance, what they've really hammered home here is about the importance of individualised care. And I think this is something that we really need to remember here. And this is really relevant to the SGLT2Is, because what we need to be doing is adopting that individualised approach to diabetes care that's tailored to both the needs and the circumstances of that adult with type 2 diabetes. And that should take into account the personal preferences, but also those comorbidities and the risks from that polypharmacy and their likelihood of benefiting from long-term interventions. Now, this is really where the SGLT2s for me come into their own. It really is about preventing those comorbidities and getting in there early with these sorts of preventions. So being able to offer people this sort of therapy is a delight for us who work in diabetes care and beyond. So what does holistic care mean? So I've been doing some thinking about this, and these are sort of the key aspects of the biopsychosocial model. And we do need to think about the physiological aspects of things, but we also need to bring in some other thoughts around what's the psychological aspects, sociological aspects, spiritual, developmental, and cultural aspects. There's quite a lot of counselling associated with SGLT2 inhibitors. How do we as a region think about how we educate people on SGLT2 inhibitors to make sure that they can follow things like the sick day rules? How do we make that accessible to all? Things like sociological, do people need support? Do we need to make sure that they're having adequate hydration through the day? Is anybody calling in on that person? So actually, although you think, oh, this is just a medicine that I'm going to add in, there are other thoughts to be had around these medications, and it's about the safe use of them to make sure that we end up with that benefit versus risk and not the other way around. So this is a patient decision aid that was included in NICE, and they're talking about, you know, are hypos happening? What are the side effects? What's their willingness to take more medicines? Do you have any health issues? And thinking about my age and overall health. So hypos, great. I mean, this drug doesn't cause hypos, which is just another added benefit to it. If you add it into a medicine that causes a hypo, little bit more caution with that needs to be taken. So normally what I would say is if you're adding it into insulin, 20% reduction on the dose, and if you're adding it into a sulfonylurea, 50% reduction. And that would be if they were relatively well controlled to start off with. Obviously, if they're miles off target anyway and you've got a long way to travel, you might not want to make those adjustments. So just on a case by case. If you're concerned about side effects, obviously we do need to be relatively robust about making sure that we speak to people about the potential side effects of these medications, most importantly probably around the mycotic infections that people can get. Mostly those can be treated once and then they don't actually recur, which is great. So it's about really thinking about making sure that you've done that counselling, that if they need, that they can get access to treatment for a mycotic infection if they need that. And then again, just around really staying hydrated. There are some sort of quite sensational side effects that have been associated with SGLT2, things like Fournier's gangrene, amputation. To be honest, these are very, very few and far between, and I think getting that across to the person is important. Although you might want to discuss it with them to safety net them, I think it is important to make sure that they realise that this has been literally a handful of cases in the world, really, of some of them. So we also need to make sure that we're thinking about all the other health things that are going on with this person. Like I said, that holistic management comes into play again. So this is kind of a screenshot of the NICE guideline, which is, as you see, a lot more busy than the Healthy Hearts guidance, which is really why we wanted to distill down what were the most important bits of this guidance, because I find this very difficult to look at. Whereas the Healthy Heart guidance just seems so much more simple and really pulls out those key elements. So in here we talk about using the SGLT2 inhibitor with proven cardiovascular benefit, and this is really important. So there are SGLT2 inhibitors that may be less compelling from an evidence-based point of view, that have not shown superiority in their cardiovascular outcome trials. And so we just need to be very careful about making sure that we are using one with proven cardiovascular benefit, because that's what we're adding it in for. We're adding it in for people who have high cardiovascular risk. So we need to make sure we're using the right one. And then just thinking a little bit about how we start it. So we want to start metformin alone to assess tolerability before adding in that SGLT2 inhibitor. We've had some national debates about this and what's a better way of doing it. Some people think just add them both on at once. It's easier to do that, and they have such distinct side effects that you would know which one was causing the problem depending on what the side effect that presented itself. So if it was something GI, likely to be metformin. If it was something mycotic infections, almost definitely going to be the SGLT2 inhibitor. However, I think for somebody actually living that experience, if they were to have a side effect and they started both at once, probably somebody's natural instinct might be to want to just stop all therapy. And so I think doing that sequential start is probably better. And I would give the prescription for both of them at once. I mean, I'd be interested to hear what my colleagues would think, but I would give both prescriptions at once and just give them some clear instructions about how to titrate that metformin, and then to add in the SGLT2 straight after the last titration of your metformin. So just a few other words about various other bits of this this NICE NG28 guidance. So there's the hypertension part. So they've really simplified hypertension guidance in general. So they're now saying the target of 140/80 for people living with type 1 diabetes. And sorry, that's a typo. 140/90 for people living with type 2 diabetes, which ties now in with QOF. But make sure that you're careful. For type 1 it is different, and again, if you've got albuminuria, avert albuminuria is different. And just to highlight really that the SGLT2 will get you some benefit from a hypertension point of view. So if you're adding in an SGLT2, you see somebody's hypertension is almost to target, it may be that SGLT2 actually gets you over the threshold of where you need to be from a blood pressure point of view. So just a bit of a reminder on that front. Also, just a reminder about self-monitoring. As I said, very rare to get hypos with an SGLT2 when used with things that don't cause a hypo. But if you're adding it into something that does cause hypos, it may increase the chance of having a hypo. So it may be that you just need to be extra cautious there with a bit more monitoring when you add that agent in initially. Just a little visitation here on the triple therapy. So a triple therapy with metformin and 2 other drugs is, if that's not effective, they've changed this slightly. So if it's not effective and not tolerated or contraindicated, you can go straight and then switching one drug with the GLP-1 mimetic. So this is slightly different to where it was before, where you had to have worked your way through 3 and then add in the GLP-1. This is now moving to a GLP-1 just slightly sooner in the pathway. So you may end up on an SGLT2 and a GLP-1, which I know I originally in my last locality where I worked, that would have been a serious wrist slap on the financial front. So but obviously clearly the benefits of these drugs far outweigh the initial investment of cost. I just wanted to quickly mention about when would you stop an SGLT2 inhibitor? Is it when the EGFR is less than 30? So this is a common question where somebody living with diabetes over a period of time, that indication for the SGLT2 may change, and we need to keep alert to that. So if you're using it just for glycemic benefit, then actually below an EGFR of 45, you're starting to get more limited glycemic benefit, and below 30, you're likely to not really have much glycemic benefit at all. However, it's still protecting your heart, which is why the licenses reflect continuing on some of these medications, although not initiating. But also it can be complicated by the fact that they may have another indication, which may mean that you can use where you can continue on an SGLT2. So the NICE guidance says, the NG28 says, offer an SGLT2 for CKD associated with an ACR of over 30, and consider if you've got an ACR of 3 to 30. Obviously you need to be on the normal baseline background therapies, but we need to be cautious because not all SGLT2s are licensed for this indication, and also there is a slight difference then in where the TA landed for dapagliflozin, which is the only one that has a TA. And this was around actually you didn't need an ACR at all anymore, and you could actually just have a declined EGFR of 25 to 75, and you can suddenly have dapagliflozin as long as you've got diabetes. So there's a bit of a confusing statements there in the NG28 that you just need to be a little bit aware of and cautious of. And that's my section. So I just wanted to sort of highlight really the key things that have changed in the NICE guidelines that are really relevant to SGLT2s, and I'll pass on to my colleague Rani.
Thanks for that, Hannah. I do know Rani's on because he has just texted me. So Rani, I think you're going to share your screens. There's probably stuff in there, content that might get into some Q&As. There you go, Rani. If you go next, there's a nice flow to this at the moment.
Thank you, Pete. I've been having a bit of IT problems, so apologies if things are a bit slow. Let's just have a look. Just share my screen. Let's have a look. Share. There we go. Can you see my screen okay?
Yeah, that's perfect. Thank you.
Thank you. Thanks to Waqas and Hannah. And I think probably the order of which I was trying to start first by giving a little bit of an overview. I won't be reiterating anything that Waqas and Hannah have done overall, because they kind of went straight to the actual guidelines that you all need to be aware of. And my approach is going to be around just thinking about the whole cardiorenal metabolic comorbidities generally, and thinking about why we are thinking SGLT2 inhibitors, and why is it that it is so important to think beyond diabetes as a sole condition generally. It is complicated, and as you know, patients with diabetes have so many other comorbidities. They usually have hypertension, hyperlipidemia, there is obesity to tackle, they've got heart failure, they've got coronary disease, cardiovascular disease generally, they've got albuminuria, they've got CKD. And for that reason, when thinking of type 2 diabetes, thinking about glycemic control is no longer the thing, though it's important, but it isn't the thing that we're just worrying about. We're thinking about how to better control all the other comorbidities that patients who have the cardiorenal metabolic condition as a whole. So whenever they think diabetes, we think beyond beyond just glycemic control. And this picture basically of the prevalence of the various other comorbidities should make us think about, you know, how do we manage all these risk factors? So I tried to look at the EuroAspire data, which is more of a European-wide. I know that we were looking at local data as presented by Waqas, but I wanted to show that this is something which is of a global concern. It is not just locally we're thinking this way. Globally, everybody is changing their thinking around management of cardiovascular disease and diabetes. This is prevalence of self-reported diabetes, including fasting, glycemic control problems generally. And you can see that a third of patients with coronary artery disease have been reporting problems with their glycemic control generally. If we actually delve a little bit more into it, and we actually do, as they've done in the EuroAspire data, they've looked at oral glycemic testing in those patients, and beyond the self-reported diabetes, they uncovered a lot of newly detected patients with diabetes and others with impaired glucose tolerance and impaired fasting glucose. Is only actually a third of patients who had coronary artery disease had normal glycemia. So we're talking about 2/3 of patients with cardiovascular disease having problems with their metabolic glycemic control generally. So that's why it is no longer seen as a single entity. It is part of a bigger picture. And that's why the ESC guidelines globally, I know this is not in line with what we are saying, but close to it, has put a lot of emphasis of the newer drugs such as SGLT2 inhibitors and GLP-1 agonists, because they are thinking about cardiovascular risk, particularly atherosclerotic cardiovascular risk and heart failure, of course, and I'll explain why that in a second. Of course, contrary to the ASC guidelines, which went straight into recommending SGLT2 inhibitors and GLP-1 agonists as first lines, even if patients who are not yet on metformin, we don't recommend that. We recommend first starting metformin and thinking after that about adding SGLT2 inhibitors, of course. The GLP-1 agonists have got a different story, which we can discuss later, but the focus of this session on the SGLT2 inhibitors. And this is, of course, just to remind us so that we don't get distracted with other guidelines of the simplified version of our local treatment guidance, which is focusing on beyond lifestyle advice. That is the cornerstone, of course, of what we start, is that we need to be thinking about what else can we do for patients in order to reduce their overall cardiovascular risk. And that's why we think we're recommending metformin and SGLT2 inhibitors as we progress. Why is this important? Well, because there is the whole polyvascular disease and issue that we are thinking, when we have somebody with type 2 diabetes, we're thinking about coronary artery disease and renal disease because they are all interlinked, and those patients who are at risk of polyvascular disease. So don't think just about heart attack, but think about patients who have a diabetes that are at higher risk of polyvascular disease as well. Atherosclerotic disease could be the lead of stroke. It could be the peripheral vascular disease. So we need to be thinking holistically about how to reduce these patients' risk when we manage them overall. And this is indeed an issue which is very much highlighted in the European guidelines, where we're no longer thinking just about heart attacks, we're thinking about the polyvascular disease overall and how can we reduce the burden of atherosclerotic disease generally. And for that reason, when we're assessing patients with polyvascular disease, we're looking at all these data as we would do in management of a patient with diabetes. We need to be thinking about what are the different risk factors they have for all this. And if they haven't got established vascular disease, as Waqas has said, if they haven't got already coronary artery disease, they haven't got stroke, they haven't got perivascular disease, then we are estimating the risk and trying to optimize the risk factors. What are the risk factors? And the European guidelines seems to consider any patients with diabetes to be a very high risk, especially if they have, target organ damage. So this is how convoluted and how all interlinked the picture when assessing patients with diabetes. It's not just about, worrying about glycemic control or just thinking about their MI or just thinking about, we are actually overall thinking about what are all the different things that are contributing or could be contributing to the bigger picture of the cardiometabolic picture for those patients. And this is the kind of things that I know that the targets might be different locally and nationally, but this is the kind of targets that ESC asks us to think about. Think about this patient's blood pressure, think about this patient's LDL cholesterol, triglycerides. I know there is a difference between the HbA1c targets, and as was emphasized by my colleagues earlier about the personalizing that rather than being strict, because we know that the tight glycemic control doesn't really show any necessarily macrovascular benefits, and therefore it is no longer the main thing we're focusing on. But this is the comprehensive look of the management somebody who's got cardiorenal metabolic. These risk factors apply to all conditions, apply to patient with established cardiovascular disease, applies to patient with diabetes without yet cardiovascular disease, and applies to patients with CKD, and applies to patients who we're managing generally as a preventative. Targets slightly differ from ESC guidelines in America, but just think about what the LDL targets. Okay, the NICE guidance talk about more than 40% reduction of non-HDL cholesterol. Practically, we think about less than 1.8 in LDL. Triglycerides are important to think about as well. And of course, thinking about the other factors such as obesity and lifestyle modifications. Now, we know that patients have shown good outcomes when they were treated with SGLT2 inhibitors. Our focus mainly in our guidance about EMPA and DAPA. And of course, there was some good evidence about reduction of MACE generally, which is the major adverse cardiovascular events. So we're suddenly become interested in this because the benefits of the glucose lowering has gone beyond just glucose lowering of using SGLT2 inhibitors. And we've got all these trials, but we've distilled that for you in the guidance that we published so that you don't get lost in all this data. So all this data, you don't have to worry about it. You just need to, we've distilled it all for you. And this is a meta-analysis overall showing of patient benefiting from SGLT inhibitors when they are on metformin, and also if they are not on metformin because they don't tolerate it, there will be benefits. The major things we worry about, of course, with patients with diabetes is that they're going to have heart failure. We know patients with diabetes, they're twice the risk of developing heart failure, and females are even higher risk of heart failure than males. And that's why, you know, it is of a great interest to see the impact of SGLT2 inhibitors in specific on the prevalence and developments of heart failure. And that's why, you know, the data that we have from a variety of trials showing that specifically about heart failure, there was a favorable outcome reducing the risk of exacerbation and development of heart failure in patients with type 2 diabetes. And this is what sold the whole idea of thinking about SGLT2 inhibitors, because remember, you're not just lowering glucose, you're actually lowering this patient's developing heart failure, and if they do have heart failure, then we have favorable outcomes. And we know trials after that tested SGLT2 inhibitors in patients even without diabetes and with favorable outcomes. And we know now that, you know, the even patient with reduced ejection fraction, we've got now technology appraisal approving their use, but now we have also data come in from patient with preserved ejection fraction showing their favorite outcome. Technology appraisal is pending, of course, but the trials are out, and one has already been presented, the Emperor Preserved. Another one is on the way to be presented in the ESC Congress, which is the one from the DAPA data. But all of them seem to be very promising, showing benefits. So heart failure, when you think of diabetes, you should be thinking of heart failure, and we want to prevent heart failure, of course, and we want to also manage heart failure in that population. So this is the general other data looking at specifically of type 2 diabetes enrolled into the different trials, and you can see favorable outcome for SGLT2 inhibitors for diabetes population when it comes to heart failure generally. Of course, the other aspects which also interlinked with all the complexity of managing patient with cardiorenal metabolic disease is CKD. Historically, we always think EGFR. We know this is not accurate. We think about albuminuria, and we know that with the risk of CVD generally and atherosclerotic cardiovascular disease generally increases as we've got the staging of CKD gets worse, and the staging is not just based on EGFR, but based on albuminuria as well. And you could have a patient with a perfect EGFR over 90, but if they've got albuminuria, then they've already got some sort of CKD that you need to be worried about. And we know that diabetes is problematic when it comes to kidney disease, and about 40% of patients with type 2 diabetes, you know, it is they're going to have probably the underlying cause for it is because they had diabetes. So this complexity of all these interlinking make us think about, okay, so what do we do about that? And again, SGLT2 inhibitors had a favorable outcome in actually reducing the development and the progress of CKD generally. And for that reason, our guidance, which is simplified, as I said, distilling all this data that we have to what you need to know practically as presented earlier, to emphasize that you are getting good outcome in terms of renal protection with SGLT2 inhibitors. So when you're talking about SGLT2 inhibitors, you are thinking about not just glucose lowering, you're thinking about all these benefits. So I'm not going to dwell into this, but this is the kind of things you need to have in mind when you think about SGLT2 inhibitors. You've got renal protection, you've got cardiac protection, you've got less and better improvement of heart failure management and developing heart failure generally. Some guidelines have already recommended it as protective for developing heart failure. The American guidelines talk about how do we prevent heart failure, and they talk about SGLT inhibitors as actually one of the approaches to do that. So this is the complexity of the management of patients, you know, where you're looking at heart, kidney, diabetes, all that all interlinked. And it seems that SGLT2 inhibitors, their recommendation need to be so emphasized that it is beyond glycemic control and bringing all these benefits. So
lovely.
I hope
Rani,
that.
sorry. So, yeah, I was going to say. I think you were just. I think you. Yeah, lovely. I was going to say that I could tell you was coming to an end, and that's perfect, Rani, because we did want to do just that. Because Wakas, I think, needs to go very shortly, and I need 5 minutes of time just to explain some resources that are available to PCNs. But let's just open it up quickly now for any questions that want to be asked now. Because we did promise that, and I can see some in the chat, and Wakas has been responding to them. If anyone wants to put their hand up for a question, just while people are doing that, I think as a non-clinical person, I can see some really kind of key messages coming out of there. As we keep saying, there's a lot of data, there's a lot of complexity. We've always tried to simplify it. As Hannah said, and as Rani said, you know, these drugs have got good blood pressure reducing qualities potentially, so you know there's an angle there as well, isn't there? So lots to be had. Is there anything that people want to ask of our clinical experts now? I can't see a hand going. Brilliant, good. Stephen, over to you.
Yeah, just the rationale for those two that you've chosen on the healthy hearts, empagliflozin and then dapagliflozin. If you could just briefly talk about that, because we've got patients on several others. So would we change them over? What would you recommend?
I'll take that one. So I definitely wouldn't change them, Stephen. I think that's probably a waste of clinical resource. I think we're all in a reasonable amount of agreement that there is definitely a reasonable amount of class effect here. And I think that, you know, we've gone off the evidence base that's currently available to us as to which recommendations we've made based on the best licenses, the best crossover, the best outcomes, etc. But the safety data, clearly a lot of that comes out of one trial associated with canagliflozin, and not even all the trials for canagliflozin. So I think, you know, from that point of view, I wouldn't consider switching anybody. I think just leave them where they are.
Wakas, do you want to say anything more about the two drugs? I know there was a slight licensing change for EMPA when we originally created this, hence why we're just changing it, because I think EMPA then got a license for heart failure, if I remember rightly. So I think that's what we tweaked. Wakas, is there anything you want to add? You may have just frozen. No, there we go.
Sorry. I just wanted to echo what Hannah suggested. So Absolutely, this is not about a script switch. This is not about switching. So for instance, if we look at just prescribing across our region, the 3 commonest SGLT2 inhibitors, in whichever order you look at, whether it's Bradford, Leeds, CKW, it will be MPEG and DAPA in one way or another. So we're not absolutely advocating that. I think, like Hannah alluded to, when we've devised this, we've looked at everyone's license, the EGFR thresholds, and also the simplicity factor. So where we can get away with using one drug that actually ticks the most boxes, purely because if you look at the data, we change that same patient, change a risk factor, the answer becomes something different. So we wanted to look at which covers the most bases, and that was the ethos behind it. But yeah, no switches. But if you are moving from a gliptin or any other therapy, then what we're hoping is that you can align to the first and second choice SGLT2.
Lovely. There's a couple of questions in the chat. One of them I'm just hoping, Waqas, you can look at. So I'm just going to pick on the EGFR one because that did come up. And Hannah, I was wondering if we just share our guidance document again, and I can do that because I'm about to share my screen again. We tried to really simplify the kind of thresholds in, and I'll just make it slightly bigger potentially in this document. And there are other sort of documents floating around, aren't they, about the sort of EGFR thresholds? But if we just take that, Hannah, I don't know if you want to just talk around this side of things. And
yeah, so the empagliflozin SPC is actually quite complicated, and it's got lots of like little tiny letters that are written in odd places, so that it is quite difficult to navigate, which is why we've tried to simplify this as much as humanly possible. So basically, the empagliflozin, you start at over 60 mils per minute. You need to be over 60 mils per minute to initiate it, and you can titrate that then up to 25 for glycemic management if your EGFR remains over 60. So that's good. But patients need to have established cardiovascular disease to initiate at a lower EGFR, basically. So that's the general gist of that. And then the dapagliflozin has a completely different license. So they just say that EGFR has to be over 15 at the time of initiation, and you carry on. So you can see that, this is the way that the drug companies play the game to a certain extent. I'm not going to lie to you. This is how they gain their market share. They will play on this, and this is how we end up turning ourselves inside out, trying to get the right one for the simplicity factor. So I think you just need to be just a bit cautious, but I think the most important thing to take away from this is, what am I using this drug for, and does it make sense that I'm continuing it? So if you want glycemic benefit, and that's the reason why you've started this drug predominantly, you are not going to get glycemic benefit really if your EGFR is below 45. So then you need to be asking yourself the question, but would it still be useful if I continued on this for the heart? Is this person a high cardiovascular risk? And if the answer is yes, then you still need it, but you probably need something else to manage your glycemic control as well. So it's just, what is it for? And then sort of the thought process that sort of comes out of that. I hope that answers your question.
lovely, thanks for that, Hannah. I'll just sorry, why has my screen gone a bit strange? Let me just there we go. Yeah, I do need 5 minutes myself, actually. So what I'm going to suggest, if people just keep putting things in the chat, if it hasn't answered the question, we will follow that up, because the purpose of today as well was just to find out the areas where people do want some support on, where are the common questions, and I think this is a reasonable one. Just in terms of resources, we've talked about the clinical searches. Just some numbers here from a West Yorkshire perspective. If we run that search, there are around 1,200 or nearly 1,300 patients that might benefit from the addition of this SGLT2 drug. Please be aware that, if you run that search, obviously a clinical review must be, taking place. This isn't like an automatic prescribe. And I think that's obvious, but I just wanted to say it for my own sanity. It might be as well that we need some other searches just to complement this work. But, we've gone for one fairly simple, excludes lots of different criteria. Hannah and I had a conversation briefly a couple of weeks ago that the numbers might be small, but actually that's not a bad thing. If we can start running some searches, and I've sat down with a couple of GPs that have run these searches and look for patients that may benefit from an SGLT2, then we can start sort of small and build up really. And I know how much pressure primary care are under, because we throw lots of other work at them in terms of CVD. So I think the lower numbers might not be a bad thing. So reach out to me if you're interested in running that search and finding the patients. We've got a website. I tell this to everyone, but the information that we're talking about today is on our professionals page. So the information on this website is both for patients and professionals. We've made it accessible in different languages, easy read, etc., etc. You know, we're really proud of that website, and we keep updating it with information that we find that's of use. Just a quick shout out to some of the other way. I mean, this is treatment guidance for uncomplicated hypertension, but you know, we know that that's a big focus at the moment for primary care. We've mentioned briefly about lipid treatment guidance. So this is our lipid treatment guidance, and then it aligns with the new national guidance for lipid lowering therapies. There are some digital solutions that, again, we talk about to PCNs about how you can use some of these digital products like AccuRx to gain information from patients, to get readings into the system. Similarly, System 1 has their patient-facing app called AMID Cares. They've got built-in functions where you can automate processes. And again, when you're very busy in primary care, that's maybe not a bad thing. Just very briefly, we do a lot of these webinars in collaboration with the community pharmacy. So, for example, we've been promoting their hypertension case finding service. But the one that I wanted to bring to life just for the purposes of this today was that they have a new medicine service. And on our website, we have lots of information about that service, some information for patients and for you as professionals. And it covers many CVD areas. And it might be actually really ideal because it covers diabetes. So those that are going to be prescribed a new drug like an SGLT2, where the medicine service, the community pharmacy, can maybe just spend a little bit more additional time with that patient to go through some of the like psychosocial that Hannah talked about, you know, and just hopefully help with that medicines adherence piece. So, you know, the services are there, they're there to be used. And that was it from me, really. So thank you for your time. Thank you to the speakers. Do follow, have a look on our website. Reach out to me if you would like to ask any questions. Follow us on social media. We do try and be active on there and promote a lot of this. And again, thank you for the time, and we will follow up any Q&As in the chat that we didn't get around to today.
Thank you. I think one or two people have asked for the slides, and you've said yes, but I can't find them, and I'm not finding them on the website either. But
the slides won't be on the website. The presentation that I've just done today is not on the website. We'll make that available to the people that have registered for this event, and hopefully Hannah and Rana, you would be happy to share yours, and I can morph them into a master deck if that's okay, and then I'll email them to everyone that registered today. Lovely. We've got thumbs up from Rani. So thanks, Rani, Hannah, and Wakas. Really appreciate the time, and I appreciate everyone's time that's joined the call today. So thank you, and enjoy the rest of your day.
Thanks, Pete. Thanks for chairing.